So discussing about the motor system examination. First you have to know the concept of upper motor neuron and the lower motor neuron. As we have discussed earlier that what is upper motor neuron and what is lower motor neuron. So you can see here this is the section of the spinal cord, and you can see on the anterior horn cell of the spinal cord starts the motor neuron, and which comes out of the spinal cord and supply the neuromuscular junction. So what are the lower motor neuron? The motor neuron which is coming out of the central nervous system, the brain or the spinal cord, and supplying the neuromuscular junction are the lower motor neuron. So the definition of the lower motor neuron, it is coming out of the central nervous system and supplying the neuromuscular junction. It can come out either from the spinal cord, as you can see here it is coming out from the anterior horn of the spinal cord and supplying the neuromuscular junction, or it can come out from the brain stem. You can see that the 12th nerve nucleus is in the medulla of the brain stem, from which the nerve is coming and supplying the muscle of the tongue. So it is a lower motor neuron. The 12th nerve is a lower motor neuron. So the lower motor neuron, the definition of which is it comes out of the central nervous system and supplies the neuromuscular junction. And then what is the upper motor neuron? The upper motor neurons are the neuron which originate in the cortex, which descend down the brain and the brain stem, and descend down, and which control the function of the lower motor neuron either directly or indirectly through the interneurons are the upper motor neurons. So these are the upper motor neuron which is controlling the function of the lower motor neuron either directly or indirectly via the interneurons. So this is the concept of the UMN and LMN, the upper motor and the lower motor neuron. So before examination of the motor system, we must understand the concept of the upper motor and the lower motor neuron. Then what we do the examination in the motor system, we have to look at the attitude of the patient, the bulk, the nutrition. We will discuss in detail the tone, power, the reflex and the gait in motor system examination. Let us discuss one by one how to do the motor system examination, what are the findings we can expect in a motor system examination, and how to interpret those findings to come to a conclusion or to come to a neurological diagnosis. Let us first discuss about the attitude of the patient. So what is the attitude in a neurological case? Attitude is nothing but the position of the limbs in a resting position. So when the patient is in the bed, or a patient of neurological disease is in the bed, what is the position of the limb? Whether the patient is flexing his upper limb or extending his upper limb. So the position of the limb is known as the attitude of the patient, or the attitude of the limb we can say. So if you see a patient of stroke, as we know that in stroke there is involvement of the corticospinal tract. Which originate in the cortex of the brain, come down, descend and crosses in the lower part of the medulla to supply or to modulate the function of the lower motor neuron. So the corticospinal tract is an upper motor neuron which is originating in the cortex. It is coming down, descending in the pyramid. So corticospinal tract is also known as pyramidal tract. So in stroke there is involvement of this corticospinal tract or the pyramidal tract. This involvement can occur at any level. Either the corticospinal tract can involve in the cortex, in the subcortex, in the internal capsule level, in the brainstem level, or sometimes in the spinal cord level also. So if there is involvement of the corticospinal tract, what will be the attitude of the patient? Say suppose the patient is having stroke in which there is involvement of the right side of the corticospinal tract in the internal capsule level, right side corticospinal tract is involved at the internal capsule level. So if I draw a cortex here, you can see that the right side, the cortex, the originating from the right side, the corticospinal tract which is originating from the right side, descending and crossing through the posterior limb of the internal capsule, and in the lower part of the medulla, this corticospinal fiber will cross, almost 90% of the fiber will cross to the opposite side, as we have discussed earlier that the 90% fiber will cross to the opposite side and will go to the left side, and this corticospinal fiber will modulate the function of the lower motor of the upper limb as well as the lower motor of the lower limb of the left side of the body. So what will be the attitude of the patient in a stroke? Remember that in a stroke, when the patient is suffering from stroke, there is involvement of the corticospinal tract, and when there is involvement of the corticospinal tract, remember that there is more weakness to the distal group of muscle more than the proximal group. The distal group of muscle is involved more than the proximal group. Both are involved, but the distal muscle involvement is more than the proximal muscle involvement in corticospinal tract lesion. So the part of the limb which is away from the body, so this will be your distal part. The hand and the forearm is a distal part and the arm is the proximal part. So in corticospinal tract lesion, there is involvement of the distal limb. The distal weakness is more than the proximal weakness. The distal weakness is more than the proximal weakness. And in upper limb, when you see in upper limb, which muscle is involved more? There is weakness more in the extensor muscles, extensor muscle of the upper limb, the supinator muscles of the upper limb, the extensor muscle of the upper limb, the supinator muscle of the upper limb, and the abductor muscles of the upper limb. This is the rule that when there is involvement of the corticospinal tract in upper limb, there is more weakness in the extensor group of muscles, the supinator group of muscles, and the abductor group of muscle. So if there is weakness to the extensor group of muscle in the upper limb in a patient of stroke, then what will be the attitude of the limb? So in upper limb, if there is involvement of the extensor muscle, you can see that in a patient of stroke, the side where there is paralysis, say in our patient, if the right side corticospinal tract there is involvement at the internal capsule level, the paralysis will be on the left side. So in this patient, there is weakness on the extensor group of muscle, the supinator group of muscle, and the abductor group of muscle on the left side. So if you look at the left upper limb of this patient, because of weakness in the extensor group of muscle, there will be flexion at the elbow joint of that patient, and if there is weakness in the supinator group in corticospinal tract involvement, there will be pronation. The hand will be flexed, the hand will be semi-pronated or pronated. The hand will be pronated. And if the abductor muscle involvement in corticospinal tract will lead to adduction of the arm. So this will be the attitude of the limb, This will be the attitude of the limb in a patient of stroke. If the patient is having lesion on the right internal capsule level, the left limb will be flexed, pronated and adducted. The left limb will be flexed, adducted, flexed and pronated. So this will be the position. And why this will be the attitude of the patient? Because the corticospinal tract involve more the extensor muscles, the supinator muscle and the abductor muscle, and distal more than proximal. So the attitude of the limb will be flexed, pronated and adducted. And what will happen in case of lower limb in corticospinal tract involvement? In lower limb there is opposite, there is involvement of the flexor muscle, there is involvement or weakness of the flexor muscle in a patient of stroke, and there is weakness of the internal rotators, internal rotator muscle. So if you check the attitude in a lower limb, the lower limb will be extended, the lower limb will be extended, the lower limb will be externally rotated. So why there will be extension and in external rotation in lower limb? Because the corticospinal tract in lower limb involve the flexor group of muscle and the internal group of muscle, internal rotator group of muscle. So there is weakness of the flexor group of muscle, which will lead to unopposed action of the extensor group and the limbs will be extended. There is weakness of the internal rotator muscle, so the external rotator muscle will become overactive and the limbs will be externally rotated and extended. The limbs will be externally rotated and extended. So this is about the attitude of the patient. So in a patient of stroke, now you can understand that in a patient of stroke, the upper limb will be adducted, there will be flexion at the elbow, the hand will be semi-pronated and flexed, the hand will be semi-pronated and flexed. And in lower limb the legs will be extended and externally rotated. Remember that the corticospinal tract involvement causes distal weakness more than the proximal weakness, and in upper limb the extensor, supinator and the abductor muscle involvement is more, and in lower limb the flexor and the internal rotator muscles are involved more. Then we come and check at the bulk of the muscle. So what is the bulk of the muscle? It is nothing but the volume. Of the muscle. So bulk is the volume of the muscle, the amount of the muscle, or we can say the volume of the muscle, also known as the nutrition. We can also look for the nutrition, as we have seen in general examination, that while checking for the nutrition we have also seen at the mid arm circumference, the mid thigh circumference. In the same way, in neurological case also, by looking the bulk of the muscle we can identify many pathologies, or we can identify the type of the lesion, as we have discussed in our previous video module, that upper motor neuron lesion, there is not much of reduction in the bulk of the muscle, but in lower motor neuron there is atrophy of the muscle because of acetylcholine not being released at the neuromuscular junction. As the acetylcholine was continuously releasing at the neuromuscular junction and continuously activating the muscle, continuously maintaining the tone of the muscle and the bulk of the muscle. So in element type there is no continuous release of the neurotransmitter and there is atrophy of the muscle, as we have discussed. So the bulk of the muscle is necessary to identify the upper motor versus the lower motor neuron lesion. So how to look for the bulk of the muscle? We can inspect the muscle of the upper limb. We can inspect the biceps, the tricep muscle, the muscle of the thigh, the muscle of the leg, and we can comparison, or the symmetry is more important. So comparing the size and contour of the muscle bilaterally. If you see in a patient and symmetry of the muscle, if you see that the right side there is atrophy and the left side the muscle volume is normal, this is pathological, it should not happen. Or there may be sometime only distal atrophy. The proximal muscles are normal, but the distal muscle, you see there is atrophy in the distal muscle in the upper limb and lower limb. So if there is a pattern, of atrophy of the muscle, either there is asymmetry or either there is proximal involvement or distal involvement, this will suggest a neurological diagnosis. We will see later. So you have to inspect the muscle for any volume loss. You have to inspect the muscle for any volume loss, and you can see that while inspecting you can find that the muscle can be a atrophy, that the muscle is atrophy, or sometimes you can see that the muscle is hypertrophy, So what happen in atrophy, or what condition can lead to atrophy of the muscle? Sometimes the patient may have generalized atrophy, that all the muscle has undergone atrophy. Volume of the muscle is reduced everywhere, in the upper limb, the lower limbs, the proximal part, the distal part, everywhere the muscle volume is reduced. That is the generalized atrophy. If the patient is having cachexia, either because of chronic infection or chronic disease like chronic kidney disease, chronic liver disease, malignancy, either because of any reason, if the patient is having cachexia, there will be loss of muscle and all the muscle might undergo atrophy. But this is not a neurological condition. Then how can you differentiate? Remember that if the patient is having weakness because of cachexia, if patient is having atrophy because of cachexia, there will be less weakness or there will be no weakness. But if the patient is having atrophy because of neurological disease, there will be loss of muscle volume. Along with that, the patient will have weakness. So if the patient is having atrophy along with weakness, it will suggest us a neurological disease. Whereas if the patient is only having generalized atrophy, generalized loss of muscle volume, then it might not suggest a neurological disease. If the patient there is no weakness or the power is normal. Sometimes generalized atrophy can be seen in patient of thyrotoxicosis. So in patient of thyrotoxicosis, you can see generalized atrophy, and in thyrotoxicosis there is an exception. Along with atrophy, the patient also might have weakness. In thyrotoxicosis along with atrophy of the muscle. And in neurological disease, where do we find atrophy? As we have discussed, in a patient of lower motor neuron lesion, there is usually atrophy. So the lower motor neuron start from the anterior horn cell, that is the motor neurons. So the patient might have motor neuron disease. The disease of the motor neuron which is in the anterior horn cell, the patient might have poliomyelitis. The patient might have peripheral neuropathy involving the lower motor neuron. The peripheral nerves are the lower motor neuron. Anything starting from the anterior horn cell and supplying the neuromuscular junction is the lower motor neuron. So the disease of the anterior horn cell, like that of motor neuron disease, poliomyelitis, disease of the peripheral nerve like that of peripheral neuropathy can cause atrophy of the muscle. So sometimes, very rarely, you can see hypertrophy of the muscle, and you can most likely see pseudohypertrophy. So what is pseudohypertrophy? Pseudohypertrophy is a condition in which the muscle is replaced by the fat. That is why it is known as pseudohypertrophy of the muscle. Actually, there is not hypertrophy of the muscle, but there is degeneration of the muscle which is replaced by a fatty tissue, that is the pseudohypertrophy. And in pseudohypertrophy, usually there is weakness. You can see a big fat muscle, but the patient power is not normal. The patient is a weak patient. So there is weakness. Along with hypertrophy, the classical examples are the the Duchenne muscular dystrophy. The Duchenne muscular dystrophy and the Becker muscular dystrophy. The Duchenne muscular dystrophy and the Becker muscular dystrophy, where the muscle tissue degenerates and it's replaced by the fatty tissue. So you can inspect the patient for wasting. Then you can also do some measurement to look for the muscle volume. What measurement you have to do? You have to measure the muscle at a 4 level. You have to measure at the arm, at the forearm, at the thigh and at the legs. So there is a particular point at which you have to measure the muscle bilaterally. In the arm you have to measure 10 centimeter above the olecranon. You have to measure 10 centimeter above the olecranon, and in the forearm you have to measure 10 centimeter below the olecranon. So the landmark is the olecranon. In the arm you have to measure 10 centimeter above the olecranon, in the forearm 10 centimeter below the olecranon, and in the leg you have to measure 10 centimeter below the tibial tuberosity. So you take a measuring tape and you measure the circumference of the arm 10 centimeter above the olecranon, 10 centimeter below the olecranon, and in thigh 18 centimeter above the knee, and in legs 10 centimeter below the tibial tuberosity, to look for the measurement. And if there is any discrepancy, then we can say that there is wasting on that particular side. Usually 1 centimeter, there is discrepancy of 1 centimeter in a non-dominant hand and 2 centimeter in a dominant limb is taken into consideration for wasting, or atrophy, while looking the bulk of the muscle in a neurological disease. Then we have to look for, so here you can see one picture of the wasting of the muscle. So you can see here that there is wasting of this muscle or the small muscle of the hand. There is wasting of the thinner muscle, the hypothinner muscle, bilaterally, symmetrically and distally. Here that is the wasting of the small muscle of the hand. You can see the tendons are visible, here, and there is wasting of the muscle. When I remove this marking, you can see that there is wasting of muscle bilaterally in the hand. That is the wasting of the small muscle of the hand. It is classically seen in motor neuron disease. But there are some other causes of wasting of the small muscle of the hand. So the wasting of the small muscle of the hand can be classically caused by the motor neuron disease, but it can be a cause of many pathological conditions, starting from the spinal cord, like syringomyelia, cervical spondylosis. It can cause because of trauma to the spinal cord, tumor of the spinal cord, and mainly the lower motor, that is the anterior horn, the disease of the anterior horn cell, that is the motor neuron disease, and the poliomyelitis. So peripheral nerve, that is the brachial plexus lesion, can also cause wasting of the small muscle of the hand. Peripheral nerve lesion like the medial and ulnar nerve lesion can also cause peripheral motor neuropathy, or neuroperipheral neuropathy can also cause wasting. Myopathy, disease of the muscle itself, can also cause wasting of the small muscle. Dystrophica myotonica is classically causing the wasting of the small muscle of the hand. And tropic disease like arthropathy, if there is arthropathy, say suppose the patient is having rheumatoid arthritis and cannot use his hand properly, that also can cause wasting of the small muscle of the hand. This is one important question that is asked every time in a viva voce examination, that what are the causes of the wasting of the small muscle of the hand. So at spinal cord level, syringomyelia, anterior horn cell disease like poliomyelitis, motor neuron disease, brachial plexus lesion, peripheral neuropathy and myopathy like dystrophica myotonica can cause wasting of the small muscle of the hand. So after looking for the bulk of the muscle, then we come and look at the power of the muscle. So what is the power of the muscle? Power is nothing but the strength of the muscle, the ability of the muscle to make a movement. That is, the strength of the muscle is power. Power can be graded from 0 to 5. The power can be graded, the power of the limbs can be graded from 0 to 5. So what is 0? If the patient is not able to move his limb at all, that is, there is no contraction, no movement, no contraction, that means there is no power, and it is graded as grade 0 power. If the patient is only able to do a flicker or trace of contraction, you can see only a flickering movement or a trace of contraction, but no movement at a joint at all. There is no movement at joint at all, but only there is flicker or little bit or trace of movement, then the power is 1. The power will be 2 if there is movement, active movement with the gravity eliminated. What I mean to say here you can see a image of the bilateral lower limb of the patient. If the patient is being able to move his leg laterally along with the bed, just slide his leg along the bed, that means that gravity is not working here. The patient is being just able to slide his leg laterally or medially on the bed itself, but the patient cannot lift the leg against the gravity, which means that there is movement, but when the gravity is eliminated, that means the patient is being able to move his limb on the bed, sliding with the bed, but cannot lift the leg. That is, the power of the patient is 2 by 5, which means there is active movement with gravity is eliminated, and the power is 3 when there is active movement against gravity. That means the patient can lift the leg above this bed. That is, the active movement against the gravity, the patient is able to lift his leg, but the power will be 4 when there is active movement against the gravity and against the resistance. So if you can see here, if I put a hand here and against this resistance, if the patient is being able to lift his leg, then the power will be 4. Against gravity and against the resistance of the examiner. The power will be 5, that is the normal power. So sometimes the power 4 can be graded as 4 minus 4 and 4 plus, 4 minus 4 and 4 plus, if there is mild, moderate or severe disability of the patient to move the limb. So at your level, the power is from 0 to 5. The 0 power, there is no contraction. Power 1, only there is flickering or trace of movement. 2, the active movement with gravity eliminated. 3, active movement against the gravity. 4, active movement against gravity as well as the resistance of the examiner. 5 is the normal power. So we will go to the patient and we will see the motor system examination, but here you understand the concept of the examination. Next, coming to discuss the most important aspect of the motor system examination is the tone of the muscle. So what is the tone? It is the resistance offered by the resting muscle. So if I make my arm loose, I relax my arm and then I try to do the movement, then I am not offering any resistance, I am relaxing and I am doing any movement with my right hand, and what the resistance I am feeling is the tone. So when the patient relaxes his limb and you try to move that limb and you get a resistance, that resistance is the tone of the muscle. So it is the resistance offered by the resting muscle to passive movement or passive stretch, that is the tone of the muscle. And as we have discussed in our previous video module, that the tone is maintained by the gamma motor neuron. Tone is maintained by the gamma motor neuron. The continuous release of the neurotransmitter acetylcholine at the neuromuscular junction is maintaining the tone of the muscle. So we have discussed that the gamma motor neuron is maintaining the tone of the muscle. And what was happening in this gamma motor neuron pathology? If the patient was having an upper motor neuron pathology, so the function of the upper motor neuron was to inhibit the lower motor neuron, that is the gamma motor neuron. So if the patient is having upper motor neuron pathology, there is no inhibition of the gamma motor neuron. So the gamma motor neuron will overfire and the tone of the patient will increase, and the tone of the patient will increase. That is known as hypertonia. That is known as the hypertonia. And what will happen in the lower motor neuron pathology? The lower motor neuron pathology itself will involve the gamma motor neuron, and there will be no release of neurotransmitter, and the tone will decrease. That the tone will decrease and the patient will have hypotonia. So upper motor neuron pathology, there will be no inhibition of the gamma motor neuron, and the gamma motor neuron will overfire, which will lead to hypertonia. In lower motor neuron pathology, there will be no firing of the gamma motor neuron and the tone will decrease, that is the hypotonia. We have discussed this concept in our previous video modules. So in hypertonia, the patient can have either spasticity or rigidity. This is important, that hypertonia has two forms. The first one is the spasticity and the second one is the rigidity. So remember that the hypertonia have two different variety. The first one is the spasticity and the second one is the rigidity. So what happen in spasticity? Spasticity occur because of pyramidal tract lesion, that is the corticospinal tract lesion. The first differentiating point is that spasticity is because of pyramidal tract lesion, the corticospinal tract lesion, and the rigidity is because of extrapyramidal lesion, like that of Parkinson disease. So rigidity will be seen in extrapyramidal lesion like that of Parkinson disease, and spasticity will be seen in pyramidal lesion like that of stroke, So and the second point is spasticity is a velocity dependent. What I mean to say here is that when you start checking for the tone, and when you increase the speed of checking the tone, the spasticity will also increase. The spasticity or the resistance will also increase. We will go to the patient and see and demonstrate you the spasticity. But here you remember that the velocity dependent hypertonia is spasticity. That means when we are checking the tone with a speed and increasing the speed, then the resistance offered will also be increasing. That is the spasticity in a patient of corticospinal tract, that is the pyramidal tract lesion, whereas rigidity is not velocity dependent. When you increase the speed, the rigidity will be constant or it will be same. And in pyramidal tract lesion, the spasticity in upper limb will be more in the flexor group than the extensor group. As we have learned here that the attitude of the upper limb in corticospinal tract or pyramidal tract lesion is flex, pronated and adducted. So the spasticity will be more in the flexor group than the extensor group in a patient of stroke, in a patient of pyramidal tract lesion, So when you will get the resistance while flexing the limb or while extending the limb, as there is more spasticity in the flexor group of muscle, so when you try to extend the limb, you will get more resistance in a patient of spasticity, and in lower limb there is more spasticity in the extensor group of muscle. So when you will try to flex the muscle of the lower limb, you will get more resistant as their spasticity is more in the extensor group of muscle. The clasp knife phenomena is typical of spasticity. What is clasp knife phenomena? So